Cranial nerve reflexes are worth knowing because they are often utilized during a physical exam to provide clues about the existence of certain deficits. Also, on certain questions, you'll get the results of a pupillary reflex or some other cranial nerve reflex, and you'll have to know what that implies in terms of where the lesion in the brain is. So let's start with probably the most commonly tested reflex, which, as you see here, is the pupillary reflex. This is what we all see in a standard physical exam. You shine a light into one eye and there's pupillary constriction. This is mediated by cranial nerve 2, which senses the light, and cranial nerve 3, which elicits the constricting response. And this mechanism makes a lot of sense, right? There's a certain ideal amount of light required for proper vision. Your pupils help gate that amount of light that enters the retina by constricting when there is too much and dilating when there isn't enough. And this keeps the amount of light entering at a happy equilibrium. Of course, too bright or too dark, there's no amount of compensating that will enable proper vision. The corneal reflex is when you brush the cornea and the eyes will automatically blink. Sensation in this reflex is mediated by the first division of cranial nerve 5, and the blinking is mediated by a branch of cranial nerve 7. This reflex is useful for testing function in a comatose patient. Again, it makes sense that you would have a mechanism that automatically protects the cornea against injury. Now that same branch of the trigeminal nerve, the first division, when it is stimulated, it causes reflex lacrimation and tearing. The efferent branch of this is also carried by cranial nerve 7. If there is some compromise in these cranial nerve nuclei, you will lose this reflex. However, this does not necessarily mean someone cannot produce emotional tears, which is really interesting. But again, these two mechanisms of tearing and blinking are meant to protect the eye from physically abrasive materials that might cause injury to the cornea. I find it really weird that the reflex crying that you get from this exam and then the tears from emotional crying are activated in a completely different mechanism. And I always wonder how, evolutionarily speaking, the kind of response for crying, which was supposedly, at least adaptively, supposed to be this protection response, how that got linked to the emotional centers of the brain like the amygdala, hypothalamus, hippocampus to elicit crying as some sort of emotion. There are a couple interesting papers on that, but this is a huge digression, so I'm going to move on. The jaw jerk reflex is elicited by tapping the jaw and looking for clenching of the masseter muscle. This would be abnormal and a sign of hyperreflexia, similar to another sign that we mentioned that occurs in the foot, which is called the Babinski sign. Now, which nerve do you think mediates this reflex? You should remember that I said cranial nerve 5 mediates the muscles of mastication, of which the masseter is one of them. Specifically, it would be the third division of cranial nerve 5 that mediates this reflex. Lastly, we'll mention the gag reflex, and some of you might have experienced this one in some non-clinical settings, but we won't get into that. Whatever your personal experience, in the clinical setting, it is also mostly used to examine patients in a coma. You would make contact with the back of the oropharynx and the patient's palate will elevate. This is mediated by two nerves, cranial nerve 9 and cranial nerve 10. We now have some cranial nerve lesions to discuss. To truly understand the effect of these lesions, you must know the pathway of the cranial nerve. As I've mentioned before, the key is in knowing the normal function of the nerve and where it travels. Cranial nerve 12 mediates the hypoglossal muscles. If it's damaged, to which side does the tongue deviate? It deviates to the side of the lesion as illustrated in this figure. Here, the lesion would be on the patient's left side because the tongue is deviating to that side. When there is a problem with cranial nerve 10, the vagus nerve, the uvula, seen here, deviates away from the side of the lesion when one says, ah, and you probably have heard, a doctor, or you may have done this yourself when you're doing a patient exam, ask the patient to say, ah, and that's one of the things that you're testing for when you do that. Cranial nerve 5 mediates mostly sensory function, but as we discussed, it has a small component to the masseter muscles. A positive jaw jerk sign deviates to the side of the lesion, suggesting an upper motor neuron deficit. And lastly, let's talk about cranial nerve 11. It innervates the sternocleidomastoid, or SCM. The way that the SEM inserts means that it mediates turning the head to the opposite side. Thus, a lesion in SEM manifests as weakness turning the head to the contralateral side. So just to make it clear, if we have a lesion on the left side, you will have weakness turning the head to the right side. Here we have an excellent image of the cavernous sinus. The cavernous sinus is a collection of venous sinusoids located on either side of the pituitary that receives venous blood from the eye and superficial cortex. I'll outline it for you to make things really clear. So here we are. Ultimately, blood drains into the internal jugular vein just like all venous sinus fluid, and it's important because of the structures that are passing through it. What exactly is inside the cavernous sinus? So we have cranial nerve 6, which lies closest to the internal carotid artery there. Additionally, you have cranial nerve 3, 4, V1, which run along the lateral wall of the cavernous sinus. Now V2 also runs through it for a very short distance before it exits via, do you remember? V2, foramen rotundum. There are also sympathetic fibers that are passing through this area as well. So, if a patient develops cavernous sinus syndrome, which results due to mass effect, what would they experience? Well, you gotta think that your primary symptoms would have something to do with the eye because of all the cranial nerves that are passing through. And you would be right. You have ophthalmoplegia due to involvement of cranial nerve 3, 4, and 6. You'd also get ophthalmic and maxillary sensory loss because of the involvement of the first and second division of the trigeminal nerve. Now, cavernous sinus syndrome can be caused by many things, including metastatic tumors, pituitary tumors, aneurysms, infections, and thrombosis. Alright, it is time for another flash quiz. Which nerve provides parasympathetic innervation to the heart, lungs, and digestive system? That is the vagus nerve, cranial nerve 10. Okay, now we're going to talk about auditory physiology. As a musician, this is really kind of one of my favorite topics and things to think about because really all sound is the vibration of some physical substrate. And that vibration displaces air, which causes sound waves. And your brain has developed this crazy mechanism to take these sound waves, just this vibration, and transform it into this very rich, complex sensation that we experience as hearing or listening to something like music, Beethoven, John Coltrane, Miles Davis, whatever it is. And so that's kind of my take on it just from, I guess, a musician standpoint or a philosophical standpoint. But for a more practical standpoint, this is actually very high yield information. And the way that you will likely see it tested is in the form of hearing loss. And so we're going to go through kind of how this is happening and where different lesions could lead to different types of hearing loss. So the problem that we have to solve, right, is how do we change these vibrating sound waves into information that the brain can use? And so sound waves are going to hit the eardrum, and that will cause the eardrum to vibrate. So you're basically just transferring the vibration, the energy of the sound waves into the eardrum. And from there, that vibration is transferred to the 3 bones of the middle ear, the malleus, the incus, and the stapes. This leads to amplification of that vibration. The cochlear, which resides in the inner ear, receives these vibrations. Within the cochlear, the basilar membrane will vibrate, leading to movement of hair cells, which fire action potentials. And that is converting the vibration that initially entered the ear and hit the eardrum into an electrical signal that the brain can use. Hearing loss is a very complex topic. But luckily for step 1, you really only have to understand it on a very basic level. The most important thing that you probably need to understand is the difference between conductive and sensory neural hearing loss based on simple tuning fork tests. Let's first look at the Rene test. And what this test does is basically compare the sound that you hear when a vibrating tuning fork is placed on the mastoid bone to the sound you hear when that same tuning fork is placed outside of the auricle. If this latter sound here is louder than here, then air conduction is greater than bone conduction and you have a normal result. right? It makes sense that you should be able to hear the tuning fork better through your ear, as that is the system designed to take sound and transfer it into the information the brain can use, than through the mastoid bone. However, if bone conduction, when you place the tuning fork here, is louder than when you place the tuning fork here outside the ear, then bone conduction is greater than ear conduction, and that is abnormal, and the patient may have a conductive hearing loss. And this makes sense. If you have something that is blocking the ear canal, then the cochlear is insulated from this sound. The sound waves coming from vibration of the mastoid will have a greater effect on cochlear vibration than sound coming through the ear canal. The second test that you can have is the Weber test. And this involves placing the end of the vibrating tuning fork in the middle of the patient's forehead. So let's draw a patient. This is a really ugly patient, but whatever. There's 2 ears. I have no idea why I'm spending this much time drawing a nice patient for you guys, but we'll work with it. Okay, so for the Weber test, it involves placing the end of the vibrating tuning fork in the middle of the patient's forehead. So our tuning fork is going to go there. Normally, you should hear the sound equally on both sides, although many people will say they can't hear anything at all. Now, if you put your finger in your ear, you will hear the tuning fork only on that side. This simulates a conductive hearing loss. The Weber test lateralizes to the affected side in conductive loss, while in sensory neural hearing loss, since the nerve does not work, it sounds louder on the unaffected side, which has a normal nerve. Sensory neural hearing loss occurs naturally as part of the aging process, and this is known as presbycusis. However, hearing loss can occur in an acute fashion secondary to a number of different causes, including various ototoxic drugs as well as extreme noise. Noise-induced hearing loss occurs due to damage of stereociliated cells in the organ of Corti. Loss of the ability to hear high-frequency sounds normally occurs first. Extremely loud noises can rupture the tympanic membrane, and this also causes acute sensory neural hearing loss. What are some other symptoms that you might see in a patient who has sensory neural hearing loss due to taking an ototoxic drug? Well, you might also expect things like tinnitus and vertigo, because remember, cranial nerve 8 also carries information from the vestibular system, which is important for balance. Cholesteatoma is characterized by a destructive growth of keratinizing squamous epithelium in the middle ear and/or mastoid process. These growths can be dangerous as they can erode the ossicles and can sometimes spread to the brain through the base of the skull. Lastly, they are also prone to becoming infected. Now, cholesteatomas can be either acquired or congenital. Acquired cholesteatomas, which are more common, can be caused by pathological alteration of the eardrum, leading to an accumulation of keratin within the middle ear. Specifically, chronic negative middle ear pressure leads to an invagination of the eardrum and entrapment of the squamous debris in the middle ear space. On the other hand, congenital cholesteatomas arise from the embryonic epidermal crest and usually arise in the middle ear, the petrous apex, or the cerebropontine angle. So the major symptom to look out for is conductive hearing loss. And this makes sense as you have a mass that's actually blocking the passage of sound into the ear. Now, once identified, what do you think is the best treatment? So the best treatment is simply to remove the growth surgically.